Welcome to Peer2Peer The Podcast. We're filming live here in beautiful Italy. Thank you both for joining me. Today we're at Ophthalpreneurs 2025 in Taormina, and today's discussion is all about the changing landscape of premium IOLs and if the new RayOne Galaxy is the lens that surgeons and patients have been waiting for. Joining me are Mr Kieren Darcy from the UK. Thank you very much for being here.
You're very welcome.
And Mr Andrzej Dmitriew, or Dr Andrzej Dmitriew I should say, from Poland. Kieren, how have premium IOLs changed over the years?
I think we're in a very fortunate time to be ophthalmologists. What we've seen over the years are a number of technological changes and ways that we've improved and seen improvements in the optics and then the way we can actually help patients.
And Kieren, are you seeing a change in patient expectations? I know we always talk about expectations getting higher, and they are. We all expect more. But what do you think about the quantity versus quality of vision expectation?
I think that the more that patients understand from speaking to other people, but also from the surgeon's expectation as well, I think expectations probably have changed. I think there's a key thing that always needs to be understood, though, that no matter what the technology is, and I know you've got a personal thing to try and cure phakia in the world.
I'm trying one eye at a time.
But, what we haven't got with any of the technology yet is to be able to mimic the natural young crystalline lens. And so I think that the one thing that's very important for patients to understand is that, there has to be some form of optical compromise with whatever we do. And that with a monofocal lens would be the compromise of the distances you're not correcting for. The key challenge with diffractive technology before, and that we still, do use today, is that you have three classical focal points. And so patients really have to learn to adjust to those three focal points. Now with neural adaptation and with the brain, it's an amazing tool. They can actually gradually increase their range. But I think the downside would always be in the dysphotopsias. And so I think, patients understanding that, the fact that actually no eye is perfect to start with. And so I get all my patients before they actually have any surgery, and this is mainly with a lens replacement. As soon as you've got cataract that's compromising the vision, then it differs. But with lens replacement, get people to go out before they have surgery at night and then just have a look at their own vision. So look at car headlights, look at street lights, and they'll all see some form of haloing or glare in their vision. But then just to understand that we can't defy the laws of physics, nor of optics, and so there has to be a compromise built in. Those compromises, however, are getting less and less with time.
Yeah. My biggest fear is that someone will invent a drop to reverse cataract. Hopefully not in our lifetime. And Kieren's right, he's talking about dysphotopsias. There is a trade-off. What actually causes dysphotopsias with these lenses?
So generally, our biggest concern with diffractive optics was that the quality of low light vision would create halo glare and starburst, which would significantly reduce patient's comfort. And that is still the main reason why people are coming back after the implantation of diffractive lenses. And they still don't see enough. The quality of vision is not good enough for them to adapt to regular lifetime duties. And that was the main switching point for us to look for other types of technologies. Because if we hit the ceiling with diffractive technology, we cannot do it much better. And then you're looking for a different technology which could limit the dysphotopsia. And really saying no dysphotopsia is basically not possible, because we have this with the monofocal lenses as well. But significantly reducing dysphotopsia means that basically the patient would be happy enough to consider that the quality of continuous range of vision and having at the same time excellent driving conditions both on day and night, and at the same time reading conditions with very good intermediates, means that with good quality and very good quantity of vision, you have a reasonable balance of these two, which matches patients' expectations. And this is what we're looking for, a step forward in terms of reducing dysphotopsias and increasing the quality of vision.
I mean, both of you have really long arms, so you've got no worries about intermediate. Think of my pain. I will definitely be needing a full range of vision lens. But In terms of those, like you said, halos, it's been previously acceptable that we're not going to get zero halos. Now, I don't know if either of you have heard of the Galaxy lens. There hasn't been a lot of hype or advertising particularly, but we should talk about the Galaxy specifically. With that spiral design, Kieren, why do you think it does give fewer optical side effects? I've definitely noticed my patients that have been implanted, their nighttime vision does seem to be much more acceptable, much fewer halos. Are you noticing that as well?
Yeah, absolutely, yeah. I think the refractive design and the way that it spirals has less of the, even with apodization, has less of the edge effect that you have with the trifocal technology. So you get less internal refraction and refraction of light. And so then, the natural design of, even when you implant it, you can see that, because actually that spiral design is actually very subtle unless you get the light on it, even when you're implanting the lens itself. Patients definitely notice less, or it's difficult, but we're doing a trial at the moment that's head-to-head. We're starting to see those effects already in the trial.
Who are you going head-to-head with?
I won't mention on this podcast.
That's fair. We'll cut that out. That's good.
Yeah.
And what about night vision? What do you think?
Yes, I think the patients are definitely noticing better night vision. I'm yet to have a patient that actually complains of having poor quality night vision with the Galaxy. And so I think that overall, but that comes down to selection again. It does come down to, it's important to select the right patients.
And Andy, what do you think about adaptation to the vision with the Galaxy lens as compared to trifocal lenses? I would ask Kieren, but he's not wanting to share his data yet, so that'll be coming. But are you noticing, as someone that used diffractive technology and then the Galaxy, is there a difference in adaptation to that new vision? Because it is all new to their brain still.
Yeah, that was definitely our hope, that the adaptation time will be shorter and neuroadaptation would be getting much faster than in case of two diffractive lenses. And one of the reasons we're getting interested in Galaxy was that both binocular diffractive lens implantation or mixing and matching EDOF with diffractive didn't meet our needs. So either we had too high level of dysphotopsia and too long neuroadaptation, or we had too low quality of near vision, right? So there was always a compromise. So we were looking for, as I mentioned, continuous range of vision. We were looking for a pretty fast neuroadaptation, and the combination of these factors was crucial factor for us. And that's what we actually found in Galaxy. And obviously, you still can have unhappy patients, like with every single lens. I mean, it's always like that. But in general, when you look at the whole group of patients based on my clinic, so you see that neuroadaptation is really fast. They can drive a car in a couple of days after the surgery. They have excellent quality of night driving, which is really excellent. And it's something that was really surprising, because we were really highlighting that they can really drive at night 3.4 days after surgery without any significant light conditions, right? And even if I was trying to prepare them, showing like pictures, how it's going to be afterwards, the same, we don't have it, right? Obviously, I'm not saying it's absent, but it's so surprising to see that so many patients don't have any abnormal light evolutions.
Yeah, I do feel like they adapt quickly to it, but the vision continues to improve, maybe a little longer than trifocal, personally. Would you say similar?
And the same with near vision. It's really unbelievable when they show us like 20 centimeter near vision with excellent 100 meter or 200 meter sharpness. So it's a balance of both at the same time, which is not a case of diffractive technology.
And Kieren, have you changed the way that you counsel patients for dysphotopsias between a trifocal and Galaxy?
So I have actually, yeah. It's been interesting to see actually the patient journey afterwards. So I still give the same information to patients about the day one. I find that it helps patients with the psychology. I ask them all to go out for a walk on the first night.
I do the same thing because I want it to be their worst possible night so that it gets better from there.
Exactly. But it gives you a point of reference, and I think it just continue to get better. And almost, I even say to them, then you can pat yourself on the back as they're neural adapting.
Now I heard that you may have implanted these lenses or recommended these lenses to your father-in-law. Now, I don't know what the family dynamics are like, whether you like him or not, but I'm assuming you get on well and you thought it was a good choice.
So this was actually in the early days. So I recommended the lenses for him to have in his eyes. And it was in the very early stage of actually Galaxy. And so in the same way as you do for every patient before you start using new technology, and you properly inform the patient, and we include it in our consent forms. I did the same with him, but it was a different conversation the night before he actually went in for the surgery the next day. And there was a very quick phone call to someone at Rayner just to say, look, are you about to cause me a divorce?
Give me the good one. And I'm still disappointed you didn't ask me to do the surgery, but that's okay. It's fine.
You were just too far in Adelaide.
I understand. It's all right.
We actually had a very similar experience with a really like a big celebrity, and I operated on a MasterChef cook, like a very famous guy, and that was like 3 weeks after I started with Galaxy. So, there is like certain risk condition which you consider, but I was really like reassured that the technology and new adaptation process would go on pretty quickly. So we did it, and after 1 week, he was really so happy out of the outcome. So sometimes you need to get the step forward, even if your self-confidence is a little behind, and just go on and you have a happy patient.
Did he go back on the show and say?
No, that wasn't a part of the contract. But it's so nice to see him like without glasses, without any problems, and he's really happy.
Yeah, it's nice. It's really nice.
I had a similar thing with my father-in-law, actually. The next morning, after he'd had bilateral sequential surgery, he was helping my daughter do her homework, and the writing was around about N4 sort of level. And then he managed to drive home later on that afternoon, which was pretty impressive.
That's impressive. That's very impressive. Yeah.
I check his vision before he
like the same. So we are operating like 75% of patients bilateral sequential. So we did the same in this guy, and it's just amazing to see how fast they go back into their duties and they drive. And
it's exciting. Good for your ego too.
Oh, yeah.
You know?
It is.
Really good. Were you nervous operating on a celebrity?
Oh yeah, it's always like that. So you never know what happens afterwards. But I'm always asking myself a question. It's like, what is worse? Do you practice operating family or someone very famous? But I still think after you cover the face, they're like regular patients, right? So
yeah. Andy, I also wanted to ask you, I was reading on LinkedIn, you've been using the Sophi Phaco machine. I've talked a lot about it, but I've never seen one. So I'd like to hear about that. And also that you are a Rayner Centre of Excellence, which I don't know why they won't give that to me, but that's okay. But I think that...
You should get Sophi.
Yeah, I need to get a Sophi, clearly. But what can you tell us about your experience with both the Sophi and becoming a Centre of Excellence?
I think that our road to becoming a Centre of Excellence was pretty long, and there were a couple of factors behind it. So we started our cooperation with Rayner with so-called lenses and the add-on technologies. Then when the EMV lens appeared, we started considering whether the monofocals could be replaced by EMV lens, just to show more quality to our patients. And actually we did it over a year ago, so we completely stopped using monofocals. So that was the second step. Third step was the introduction of Sophi and Galaxy, and that happened last year. And I guess both factors played a very important role in our practice, because first of all, Galaxy broadened our spectrum of IOLs which we had, and we're finally able to propose to our patients like a technology which is safe. I would say light condition free, without saying dysphotopsia free, which is obviously impossible. But we could be really reassured that we're proposing to patients who are like nighttime drivers and really demanding patients extremely high quality optical technology. So at the same time, having full range of vision and optical quality was very important to match. So when Sophi appeared, I think it was an excellent addition to our portfolio. And with our premium patient-oriented practice, with like 75% of patients selecting advanced technology IOLs, 75% of patients selecting laser cataract surgery, and more than 70% of patients having bilateral sequential surgery, we needed extremely high quality of technology at the same time. So when I looked at Sophi, I looked at a couple of factors behind it. First of all, it's extremely predictable and safe system. Second, in the times right now, especially in Europe, it's extremely important to remember about sustainability. And that's one of the most important features.
One of the things I like the most about talking about it, at least, is that the cassette can be used for multiple cases, right?
Yeah, it's a day cassette, and at the same time mobility. And it's so excellent to see the Phaco, which you can move in whatever place in the room you want, and do that the whole day with the Phaco, which is not connected to power. And it's such a ridiculous problem which we haven't seen before, right? And it's just amazing that the nurses can just switch the position of the Phaco during the day, whatever they like. The tubing installation is so easy with the day cassette. And what is the most important factor for me is actually the fluidics. And I think the combination of 3 pumps and the setup of IOP control with the peristaltic pump and the flow control, at the same time, the safety of the Venturi pump or optional Venturi pump, is giving you like really safe environment of what you see in the machine, both in the IOP control and the safety for the personnel and the patient. So lots of factors behind which combine into one.
I didn't realize about the maneuverability until I was thinking the other day, moving from left to right, and how much of a diva I am, that where the cord lies really disrupts my ergonomics. It is actually really annoying. So it's a battery-powered machine?
Oh yeah, and it lasts really long. So I was really surprised during my first day that we were just unplugging the machine at the beginning of the day, and we're doing like the cases, and I was like, aren't you going to plug it in? And they said, no, you don't need it, right? So it's just amazing. It's just such a simple thing, and right now we're getting so mobile, and our Phaco systems we're not, right? And sometimes we really need it. We're switching positions, and we're trying to achieve something more in terms of positioning the patient itself. And suddenly you're getting a very simple solution, right?
And does your team like it?
Oh yeah, and the nurses love it because they don't need to ask me like where do I want to have it, because they position it in a way they want. And at the same time with the day cassette, the introduction of new tubing is so fast and so easy for them. So obviously you need to get through the learning curve. You need to set up your parameters like with any machine, right? Same for your personnel. But if you see your personnel after 2 cases doing that like they did it like in 3 years, that's really encouraging you. So that's another reason why we started.
Yeah, that's really cool. Did I hear also that it does voice commands? Or did I dream that?
Oh yeah, and I really love it because it's set up in Polish as well. So we have all the messages from the machine
that's awesome.
are in Polish as well, which is really nice, including my name. So it's like you feel that nice.
So someone Australian isn't calling you Andy.
Oh yeah. That's very cool. So lots of really nice and
nice features.
Potentially, evolving features. Yeah.
Oh, that's awesome. Would you recommend it to Kieren?
Oh, you should try it
now.
It's a sound bite.
What is really important is I have quite a lot of refractive lens exchange patients, and I was so surprised to see how fast and how effective it is in very soft lenses, because sometimes with many Phaco systems, they're pretty used to having very hard cataracts, right? And then you see those soft lenses, and it's not actually that suitable to remove it. And with Sophi, it works well.
Ah, that's awesome. So Kieren, with the Galaxy lens, obviously it's working well for you and standard patients, family members. What about those tricky patients, like post-LASIK patients, post-refractive surgery?
I think this is where this lens really stands out by itself. In the post-laser patient, you classically have to be more cautious, depending on whether they've had myopic or hyperopic LASIK. Which way you push the spherical aberration with the treatments, you need to be more cautious. The key thing with the Galaxy is it's got negative spherical aberration built into it of minus 0.17. Therefore, even with patients that have had a hyperopic treatment, as long as you're keeping them within a reasonable range of around up to minus 0.6 spherical aberration, it's very well tolerated. So for those patients that have had myopic LASIK, it's a great lens because you're adding negative spherical aberration back into their optical system and actually helping them with their overall contrast sensitivity at the same time.
Oh, that's good to know, because it's the post-hyperopic ones that I worry about, those weird shaped eyes. And you've used it in some?
Yeah. So we used it in post-laser eyes. Yeah.
Going well?
Yeah, going well.
And Kieren, on the flip side, as potentially a previous trifocal user, do you see Galaxy eating into the trifocal market?
I think without doubt. I've already started to see it in my own practice. We've started to shift largely across the Galaxy now from, the trifocal technologies we were using before. I think it'd be interesting as the evidence and the data starts to come out, and we're hopefully adding to that later this year. But I think that early results show that supports that Galaxy probably will start to eat into that market in a big way.
Oh, exciting times.
Yeah.
Andy, Kieren, thank you very much for joining me. I think we've learned a lot. Sounds like both of you are very impressed with Galaxy so far, which is pleasing to see. And Andy, the Sophi machine, one day I'll see one, but it sounds very exciting. It sounds positive, not just from an environmental point of view, but ergonomics, enjoyable in the theatre as well. So that's great.
You'll love it.
Thank you. And thanks for joining me, and enjoy the rest of your time in Italy.
Thank you.
Thanks, guys.